So if people are compliant, well, one of the issues that often comes up is a newly diagnosed patient who's in infancy or age 1 or 2 or even 3 or 4, and the parent first learns about this disease, knows nothing about it, reads some of the old literature or even things on Google and so on that scare the daylights out of them. And in addition, they may get a physician who knows something about CGD, but not enough to know, what the true long-term outlook is. They know that we're now offering transplants for a lot of CGD patients, and that transplants can be curative. And so they think they've got to rush into this. That is not just the family, but sometimes even the local transplanter or the who's not an expert at CGD thinks, God, this infant's got to be transplanted. And transplants for some kinds of immune deficiencies must be done in infancy, but infants are much more sensitive to the conditioning agents that are used. And I strongly recommend having a CGD patient get into their age 2 or 3 before they go forward with a transplant. Does that mean nobody would ever get in trouble and maybe even die of their CGD in childhood? Things can happen, but we've done so much with prophylaxis to keep CGD patients well that, as I mentioned, most CGD patients now survive into adulthood even without a transplant. And so there is no rush. And what you need to do is consider very carefully when, where, and with whom you want to do something like a transplant. And I'll talk about transplants in a little bit. But what you don't want to do is feel you've got to make a decision right away that there's some emergency in a child who's just been diagnosed with CGD. Sometimes, even if it's an older child who's been diagnosed at age 6 or 7, where a transplant, might be considered sooner rather than later, there's no rush. We do really well at taking care of CGD patients, and you've got time to think this through very carefully so that you do the right transplant for your child at the right time and place. It's very interesting. I would say, until perhaps 15 years ago, experts in the field of CGD were not particularly enthusiastic about sending CGD patients to transplant. And there was a transition period where we got better and better at keeping children healthy. And now we've come to realize that many of these children who reach adulthood start to have problems from small, modest infections and other issues, getting severe inflammatory bowel disease, maybe in their 20s and 30s, suddenly beginning to get inflammation in their lungs that may progress to the point where they're having trouble breathing and so on. And so opinion has changed. People have come to realize that if you don't do anything for healthy children who are well managed with CGD, they may grow up to be not so healthy adults. And so we've begun not just to consider transplants for CGD children who get infection after infection or have other problems in childhood, but to begin thinking of the broader group of young CGD patients as thinking that transplant should be considered. But the problem was, 15, 20 years ago, transplants weren't as safe or as good as they are now. Not that transplant still isn't a big deal. It's a big mountain to climb for people, and there are dangers, including graft versus host disease and so on. But the vast majority of experts in the field of CGD are coming around to the idea that if a patient has a really well-matched donor, that transplant should at least be talked about and considered. I think that every CGD patient parent should be at least talked to about transplant as an option. That doesn't mean every patient should go to transplant, because as I said, I don't think there's an emergency, and we do better and better. with transplants over time. Lots of new ways of doing this are being invented every year, so that it's a race between how soon do you need to do a transplant, or how long do you wait before transplant gets a little better and better. That's a difficult balance that I'm not going to answer here. What I will say, though, is that the great majority of CGD patients who go to transplant now with a good, a well-matched donor get through that transplant and get cured of their CGD. So it really should be talked about and offered to all patients with CGD. As I say, some of them are doing quite well, and it's hard to say, gee, why should I go to a transplant now? But you don't know what child who's 10, 11, or 12 and doing really well with his CGD is going to be a 25-year-old with terrible inflammatory bowel disease. Just don't know. And so I think these things should be talked about and at least offered. I certainly wouldn't push anybody who seems to be doing very well with their CGD to rush to transplant, but it should be discussed. And certainly any patient who seems to have infection after infection, or problematic inflammatory bowel disease, or is beginning to get inflammatory lung disease, should probably consider going to transplant before this gets worse. Because these kinds of things, these inflammatory problems, don't get better over time. They slowly progress and get worse. So you want to do it when they first appear, because then you know that's a patient who's got this problem and it's likely to get worse over time. So you should try to consider transplant.